Welcome. This activity is intended for U.S. healthcare professionals only. The following presentation from Answers in CME is part of an educational activity titled HoFH in Focus Practical Strategies for Early Detection and Lifelong Management. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated.
Hi, this is Sam Gidding, and with my colleagues Pam Morris and Allison Jameson, we're going to present Homozygous Familial Hypercholesterolemia in Focus, Practical Strategies for Early Detection and Lifelong Management. Our speakers are myself, this isn't working very well, Pam Morris, who's professor of medicine and cardiology in South Carolina, and Allison Jameson, who's from the Family Heart Foundation. I'm at Geisinger. Those were our disclosures, and these are the objectives for this presentation. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals. Answers in CME is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. You can earn credit and evaluate this event by completing the evaluation, and also in the future, let us know what topics you're interested in. We will have a Q&A at the end of the presentations. There's an Ask a Question tab where you can type in your questions. So in today's program, we'll discuss advanced screening and diagnostic approaches for HoFH. We're going to spend a lot of time talking about treatment, but mostly we're going to do this through real-world HoFH clinical case scenarios. And these are quite intricate and will introduce all the difficulties that you face in treating these complex patients. Our first case is Isaiah, and he's a 38-year-old male with a recent MI and a history of dyslipidemia. So he's 38. He has had his MI. He's been very healthy. He doesn't smoke, doesn't really drink, is married, and has 2 children. He had a physical 5 years ago. His LDL was 315, and he took a statin for about a year. He's had no further follow-up. In his family, his mother has very high cholesterol and had an MI at 58. His father has diabetes, but does not have any known heart disease. When you evaluate him, he's pretty healthy. He's got borderline blood pressure, borderline weight. He has no physical stigmata related to HoFH, no xanthomas, ARCUS, or other stigmata. His total cholesterol is 394, triglycerides 85, HDL 55, LDL 322, and you've gotten an LP little a and it's elevated at 61. So here's our first question for you. Would you evaluate this patient for FH? Yes, no, or you're not sure? Okay, looks like everybody's pretty, or most people are pretty certain this patient should be evaluated for FH. And I think that's pretty straightforward because his LDL is over 300. Now, in it basically lifelong LDL-C exposure is related to heart disease. The higher your LDL over the life course, the more likely you are to have a heart attack. And you can look at the general population as essentially 3 groups: common hypercholesterolemia, heterozygous FH, and homozygous FH. There's substantial overlap, however, across these groups. And at the high end, once you get an LDL above 300, there is overlap up to about 500 with HoFH, so you could have either. So we know that his LDL today is 394 and Isaiah's had a heart attack. What additional information or testing would you obtain?
So, Sam, I can sort of chime in here just a little bit. I may be a little bit spoiled, but in this gentleman with two young children and a family history, I'd be very interested in genetic testing for him. Um, I think you have a lot of experience with this in terms of requiring a genetic counselor to speak to the results, et cetera. So I'd really be interested in your thoughts as well.
Yeah, I think anybody whose LDL is over 300 and doesn't have secondary hyperlipidemia would benefit from genetic testing because they could be heterozygous or homozygous, and it could have a big impact on treatment. And then I think you bring up the very important issue of identifying family members as early as possible for early treatment, particularly in the setting of someone who's already had a heart attack. So, we have gotten a workup, and turns out he has 2 different alleles, associated with FH. One is an LDLR variant with partial residual function, so-called receptor defective, and he also has an ApoB variant. So how would you interpret these results? Pam, do you wanna take this, or you want me to just keep.
Sure. Well, actually, I'm going to turn back to you here in just a second. I mean, I think this is a very interesting result. Some of it is a little positive for me, as opposed to having an LDL receptor null, which is in absolute no activity, which makes it more difficult to treat because of the less responsiveness to medication. This is a receptor defective, so that's little encouraging to me that he may have better response to therapy. And this is I'll let you speak to the nature of calling this HoFH in the setting of a compound heterozygote.
Yeah, so this is why the formal terminology is now changed to biallelic. So he actually has 2 variants associated with FH, one in the LDLR gene, one in the ApoB gene. Both of these are associated with somewhat lower levels than the LDL null. So this explains why he is, quote, a homozygote, but has an LDL in the 390s. So this is a complicated patient, but as you point out, is highly likely to be responsive to medication. And here we can see the LDLR rap PCS is very unusual. This is true homozygote PCSK9 variants. ApoB, anywhere from 5 to 40% of the population, depending on where you live. And then LDLR, which is the most common and is anywhere from 60 to 90% of the population, again, depending on where you live. So, as we've discussed, the genetic confirmation of biallelic pathogenic, likely pathogenic variants is really how we currently diagnose a homozygous FH today. How about genetic testing? You brought up that this is not commonly done in the US. The cost. In our experience, the typical cost is actually about $100 after accounting for insurance and programs from genetic testing companies, but the cost can be up to about $250 out of pocket. Patients will have issues about privacy, and then there's interpretation of variants of unknown significance. In my experience, these generally do not impact cholesterol that much, though there are some that do. However, in people of color, because they are less well studied, you're more likely to have pathogenic variants interpreted as VUSs. In all these situations, genetic counseling is extremely helpful with the interpretation. So what happened? So he started on lifestyle and diet. He got a high intensity statin plus ezetimibe, and that dropped the bottom out of his LDL from 322 to 140, as you would expect, based on his genetics. A PCSK9 inhibitor was added to get his LDL below 70 for a prior MI. His LP little a also came down, And this emphasizes the importance of combo therapy and aggressive treatment in the setting of a prior MI. So this is a key takeaway is early initiation of lipid-lowering therapies improves outcomes in patients with HoFH. So if this person had been identified much earlier in life, it's highly likely his heart disease would have been delayed or potentially prevented. Um, and we know that the LDL level at presentation drives all-cause and cardiovascular mortality in these patients. This is data from about 130 long-term follow-up patients in the UK and South Africa, clearly stratifying patients by presentation, LDL cholesterol, and outcomes of heart disease and all-cause mortality. So the earlier you recognize this and decrease the chronic exposure, the better outcomes your patients will have. So we also did cascade testing on his children, and these results are actually pretty interesting. He had one child with a normal cholesterol and one child who had the LDLR mutation, an LDL of 202. And this points to the biallelic scenario here. This father, because his genetic variants are in two different genes, could actually have a child who has exactly the same condition as him. He could have a child with a single LDLR or single ApoB, or he could have a normal child. Um, who else in this family should be screened, however? And would you treat and monitor the 11-year-old? Your thoughts, Pam?
So, technically all first degree relatives. So, we didn't talk about whether or not Isaiah has brothers or sisters, but I think that, and whether they have children. So, that certainly would be of interest. And as we'll talk about later in the program, many of the treatments for HoFH are FDA approved in children. And so, by all means, with a father with premature disease and homozygous FH, the child would certainly be a candidate for therapy in my practice and by guidelines.
Yeah, so this is a child with heterozygous FH, LDL over 190. So getting started on a statin of moderate intensity will highly likely get this child to goal, which should be under 130 for a child with heterozygous FH. So this is the cascade testing algorithm, probable FH index case. Offer LDL-C and genetic testing to first-degree relatives if FH is confirmed. Include genetic counseling and risk notification of further relatives. FH not present, you then discuss the risk of the patient's elevated cholesterol and continue according to guideline-related therapy. So when diagnosis comes late, the impact on patients and at-risk families, Allison will give her perspective.
So, hi, my name is Allison Jameson, and I live with homozygous familial hypercholesterolemia, or HoFH. And I want to share a little bit with you today about my journey to diagnosis with HoFH. So, my family has a long and pretty scary history of early heart disease. My paternal grandfather had a heart attack at 42 when he passed from that heart attack. He also had three siblings who died from early heart disease. My own father had his first of many heart attacks when he was only 28 years old. But given their family history, they weren't really even surprised that it happened. Now, my family was lucky. They recognized that this was probably something genetic that was causing this pattern of heart disease, and they even got so far as to call it genetic high cholesterol. On my mother's side of the family, the history was less pronounced. My maternal grandfather did have a heart attack in his early 50s, but that was given the reasons given were that he had smoked early in life or and he had a stressful job. It wasn't seen as anything genetic. So when my parents got married, they knew based on my dad's experience that it was possible that he could pass this on to his children, but nobody talked to them about what that risk could look like. So when I was 3 years old, I developed these bumps on my elbows, knees, and Achilles. And no, my parents weren't very worried about it. They didn't recognize it. They took me to a dermatologist who said, oh, it's probably molluscum contagiosum. So they weren't worried about it. But still, when I was 5, given my dad's history, my parents decided to have cholesterol levels checked for myself and my 2 siblings. And for all 3 of us, those levels came back high. My brothers and sisters was high, similar to what my dad had experienced, but mine was really high, like close to 900. So all of us were diagnosed with familial hypercholesterolemia, FH, but given the apparent lack of history on my mother's side, we were just told that I had severe FH. And that's the diagnosis that we lived with. Several years later, when I was about 13, I was also diagnosed with supravalvular aortic stenosis, but nobody said that that could possibly be related to my FH.
Okay, question 2. A 9-year-old girl is diagnosed with homozygous familial hypercholesterolemia due to a pathogenic LDR variant. Which family members would you prioritize for cascade screening? Only her parents, all first-degree relatives, parents, and siblings, only adult family members with elevated LDL-C, or only relatives with a history of premature heart disease? All right, so 87% say all first-degree relatives, and that is the correct answer. I think because of variation in LDL levels, that just checking the adult members with elevated LDL-C is going to miss people, and it certainly is going to miss siblings and children. All right, Pam, it's your up.
Great. So thank you so much, Sam. So let's move on to the next case. This is Melissa. So Melissa, let's meet her. She is referred for xanthomas. So she is an active 25-year-old female with xanthomas, otherwise healthy. She is a competitive field hockey player and exercises regularly. She doesn't smoke or drink. Both of her parents have high cholesterol and take statins. Her paternal grandfather had an MI in his 40s. Her maternal grandmother died at 52 in an automobile accident, and her maternal grandfather died of cancer. She is in a serious relationship and is contemplating marriage. Now, are there any red flags here when we do our physical exam here? We see vital signs look great, weight is great, but she does have xanthomas on her ankles, her heels, between her fingers, and she does at this young age have bilateral corneal arcus. So she has evidence of tendon thickening, and everything else on exam is normal. Now, what does the clinical presentation of HoFH generally look like? Well, it's not at all unusual from a dermatologic point of view to find cutaneous, tuberous, and tendon xanthomas. You can also have these interdigital xanthomas between the thumb and the index finger, and this is pathognomonic for HoFH. Obviously, systemic findings, and the thing that we're most concerned about is the very high risk of premature atherosclerosis. Some other additional findings that are not always present are arcus, the arcus corneae, and aortic disease can be present. Here are just some pictures that you can see here. Upper left-hand corner, those are the extensor tendon xanthomas. Bottom left hand there, the elbows. Center, a typical Achilles xanthoma. Upper right, the corneal arcus, again, not always present, or down below the xanthelasma, not always expected to be present. Now, as you evaluate Melissa on her lab results, all of her other labs are normal, but the lipid panel results are striking. Her total cholesterol is 902 milligrams per deciliter, triglycerides 55, HDL-C 61, LDL cholesterol 830. Her lipoprotein little a level is 30 milligrams per deciliter. So, Sam, I'm interested for you. Do you treat this as a definitive HoFH, or do you consider a differential diagnosis? Are there other diagnoses that might be associated with very elevated LDL cholesterol levels?
Well, I think with the physical findings, particularly the interdigital xanthomas, you can say this is HoFH. I know we're in a physical exam historically, like, people don't even do it, but that makes the diagnosis. Uh, in typically secondary hyperlipidemia, LDLs are 300 to 500. I have seen in a couple of rare scenarios LDL this high from other scenarios, like severe liver disease or uh, some other very odd scenarios. But I think this is HoFH until proven otherwise.
Yeah, I do entertain things like primary biliary cirrhosis with lipoprotein X, or nephrotic syndrome is another one that you can think about. Really, hypothyroidism, not so much at this level, I think. But in general, with hypercholesterolemia, it's important to think about secondary causes. But in this case, the findings are pathognomonic.
Yeah, it should be clear, like it could be diet or something. So I agree. This is HoFH.
Of course, it's hard to eat enough cheeseburgers to get an LDL of 830 milligrams per deciliter. So
I didn't want to delay the thing, but I have a patient who ate himself to that high. So
hard to do. But so let's go to polling question number 3 here. And so, what's your take? What are your immediate therapy choices for this patient? Would you do statin monotherapy, statin and ezetimibe? Would you go directly to LDL apheresis? Or would you think about first as an LDL receptor independent agent? We'll see what the polling says here. Um, um, Sam, I think you can see the polling. I do not. Do anything you want to speak to the results of the polling?
well, it's interesting. It's about 50-50 statin and ezetimibe and LDL are independent agent, which is kind of interesting. The guidelines say statin and ezetimibe with very rapid follow-up and then move on. Um, so I think this is an enlightened audience in that sense. Uh, it's interesting that people would just jump to an LDL or independent agent.
Okay. So let's look at this slide here. What are the available therapies that are FDA approved for homozygous FH, their ages, their indications? And the two most effective statins, so there are other statins that are approved in HoFH. The two most effective, obviously, atorvastatin is FDA approved ages 10 and above. Rosuvastatin ages 7 and above. So obviously could be used in this patient. The cholesterol absorption inhibitor ezetimibe ages 10 and above. The ANGPTL3 inhibitor, which we'll talk about in a moment, evinacumab, is approved for ages 1 year and above. That is the LDL receptor independent agent we'll talk about again. Now, for the two PCSK9 inhibitors, alirocumab is FDA approved age 18 and above for homozygous FH. It is approved for heterozygous FH at age 8 and above, but we do not have data in younger children with homozygous FH. Evolocumab 10 and above, and the microsomal triglyceride transfer protein inhibitor lamidopide, which we'll talk about in a moment, is FDA approved ages 18 and above. So a number of agents that would be available for this patient. Always important to think about when we're looking at patients as young as Melissa, what are the key safety considerations? Obviously, the statins we're very familiar with in terms of myalgias, rarely rhabdo, and liver enzymes are generally transient, not worrisome. Similarly with ezetimibe. Evinacumab, really minor side effects, some occasional nasopharyngitis, temporary flu-like symptoms, dizziness, runny nose, and some nausea. PCSK9 inhibitors, myalgias with alirocumab. This is primarily seen in adults. Um, Rare angioedema with evolocumab. And then lamidopide is really the important one to remember, and that is that it has a black box warning for elevations in hepatic transaminases, increase in hepatic fat, GI tolerability issues, and it is available for in a REMS program which does require prescriber training. Now let's go to our next test your understanding question here, number 4. So this is, you see a 38-year-old man with homozygous FH, and he is stable on high-intensity statin, ezetimibe, alirocumab, and lamidopide. Routine monitoring reveals new transaminitis. Which therapy class is most likely responsible? Alirocumab, evinacumab, ezetimibe, or lamidopide? Sam, I'll let you speak to those results.
Yeah, so lamidopide is most of the people, and that's the right answer.
Great, perfect. Smart group here at working with us today. So let's talk a little bit about what Melissa's LDL cholesterol goals should be. On the left-hand side are the results for patients who do not have, this is primary prevention like Melissa, does not have clinical ASCVD, and do not have a genetic or clinical diagnosis of FH. We would typically want her LDL cholesterol to be less than 100 milligrams per deciliter and add additional agents if she does not achieve that goal. On the other hand, when there is clinical ASCVD, these patients must be treated much more aggressively with an LDL cholesterol goal of less than 55 milligrams per deciliter. So let's follow up on Melissa. So she was initiated on a high-intensity statin therapy, which had minimal change, LDL cholesterol of 802 milligrams per deciliter. PCSK9 inhibitor was added. And after initiating this, her LDL cholesterol remains at 798 milligrams per deciliter. So Sam, what would you say would be the next step for her?
Well, it's always a cruel shock when you start these drugs and the numbers don't change. But I think our audience, by their response to the prior question, actually knows the answer. I think every HoFH patient needs ezetimibe. It can have a huge impact independent of the other drugs. And certainly, this is pointing towards an LDLR independent treatment strategy in this patient, and also brings up the question of what is her genetic defect.
So prescient. So her genetic testing results are very important. And so, because of her poor response, she proceeded with testing. And what she has are two different null variants. So, LDL receptor null variants, which a true biallelic loss of function, which makes it very difficult to treat. And Sam, based on that, how would you think about future therapy?
Well, I think you've got to move straight to LDLR independent treatments. But remember that in my experience, once you get on the LDLR independent treatments, you can get an extra bang from statins. So I wouldn't abandon the statins. I probably would abandon the PCSK9, but I'd be jumping to LDLR independent treatments, of which ezetimibe and evinacumab are you know, the are the safest. And you've discussed the other drugs as well.
Right. So this again, what you were discussing is just really the challenges of treatment in homozygous FH and the impact that the type of LDL receptor mutation or variant has on the response to treatment. When patients have an LDL LDLR negative or null variant, they have complete absence of the LDL receptor protein in receptor negative null patients. That means that their functionality is less than 2%. And remember that almost all of the currently available strategies, whether it's statins, ezetimibe, bempedoic acid, the PCSK9 inhibitors, all function by upregulating the LDL receptor. In these LDLR negative patients, that mechanism is likely to be highly ineffective. Now, in those who are LDLR defective, as was our first patient, Isaiah, there is some functionality to the LDL receptor protein, 2 to 25%, and we can expect a little better response to those treatments that upregulate the LDL receptor. Now, here's just some data. What data do we have with some of these therapies in homozygous FH? This is data from the Tesla Part B trial with evolocumab. This is a double-blind phase 3 multi-center trial evaluating it in patients with HoFH 12 and above. The response to evolocumab was related to the underlying genetic defect that caused the HoFH, and there was a broad range. There was anywhere from 41% reduction in LDL cholesterol in those patients who had LDL receptor defective defects to no actual response in patients with 2 null receptor defects. So considerable variation in response, and the variant makes a difference. Now, here is some more data from TauSig. This is a subset analysis of a multi-center study evaluating, again, patients 12 and over with homozygous FH. Most importantly, here you can see in green that those patients who had a LDL null defect, there can actually even be an increase in LDL cholesterol, but really no meaningful difference. Now, what about with alirocumab? Same thing we see here on the left-hand side. This is from Odyssey homozygous FH. And here you see that the LDL cholesterol changes are highly variable in those patients who have a null receptor mutation. So not expected to see much change there. Now, what would be your next step then? So in interpreting Melissa's, and I think we've talked about this a little bit, but we're going to think about this for our audience. So she has profound statin and PCSK9 inhibitor resistance due to a true biallelic loss of function. What would our audience recommend as next steps? No change needed, add evolocumab, add evinacumab, or begin apheresis. Actually, I think this is not a polling question. I think this is, Sam, I'm going to ask this to you, and I think we've really pretty much we've discussed this, but there are multiple options there. What would be your next step?
Well, I would certainly be on ezetimibe and then quickly add evinacumab and look at the results. I actually wouldn't expect to get to goal with those 2 drugs. I would then add a statin back in to see if you get, some further addition to the once you're on these other 2 drugs. And then we may be thinking about other therapies as well.
Right. So let's look at the response, why evinacumab is such an important tool in our toolbox in HoFH. So remember, evinacumab is a monoclonal antibody to ANGPTL3, and it is, again, functions independently of the LDL receptor. This is data from the ELLIPSE trial, again, a double-blind placebo-controlled trial in patients with homozygous FH 12 and above. Now, the patients in circles are those who have a null variant, so both alleles are null. whereas those in the triangles have non-null. So they do have some functioning LDL receptor. What you can see is that in both groups of patients, there's a 43 to 49% reduction in LDL cholesterol with treatment with evinacumab. So really important therapy in these high-risk patients. What do the current guidelines say? So here, we've talked at length about all of the therapies to the left, the high-intensity statin, ezetimibe, the PCSK9 monoclonals, bempedoic acid. We have limited data in HoFH, but also can play a role. But really, the go-to therapies here are going to be the LDL receptor independent therapies, including evinacumab or lamidopide. So what about treatment modification and 2-year follow-up for Melissa? So she escalated to ezetimibe, an ANGPTL3 inhibitor, continued the statin or LDL decreased to 210. Her xanthomas resolved, which is always wonderful to see. I'm sure we all see that with homozygous FH with treatment. She's now married and planning pregnancy. Her LDL cholesterol is still 210. It's better, but it's above target. So, Sam, which of her drugs have to be stopped when they decide to try starting a family? And what are the options that are available for her?
Well, there are very few options. You're going to convert to a rosin or bile acid sequestrant. Lipoprotein apheresis in someone who's this high would certainly be a consideration. And you can continue the statin. There now is you're allowed to use statins during pregnancy if you think the patient is high risk. But the other drugs are currently not recommended in pregnancy.
So just a refresher for everyone. So here are the FDA revised criteria for lipoprotein apheresis, and specifically, our patient falls into Group A, which is that at baseline she is a functional hypercholesterolemic homozygote or homozygous FH with a baseline LDL cholesterol greater than 500. Also updates the other group B and C are heterozygotes. And then there is the group D indication for those with atherosclerotic disease, elevated LDL, as well as an elevated lipoprotein a, which we won't discuss here today. So considerations for the rest of her family, it would be important to have FH testing for her spouse or partner to inform their decision. And then, of course, as we've discussed, cascade testing for her first-degree relatives. And I think in the interest of time, we'll move on and let's go to the test your understanding question number 5. So a 28-year-old woman with HoFH remains refractory to high-intensity statin, ezetimibe, PCSK9 inhibitor with an LDL of 220. Genetic testing reveals an LDL receptor null mutations. What is your next step? Discontinue all therapies, prioritize an alternative LDL receptor dependent therapy, select an LDL receptor independent therapy, or proceed directly to LDL apheresis. So please put in your answers. And Sam, I'll let you speak to those results.
Yeah, so I think we've beaten this one pretty hard, and the majority are selecting an LDLR independent therapy. Um, and a few people are going to apheresis. There are a few people who said an alternative LDR dependent therapy, and that would be incorrect.
Okay. So let's go to question number 6 here and test your understanding. A 35-year-old man with genetically confirmed HoFH with LDL receptor defective mutations has a partial response to statin ezetimibe PCSK9 inhibitor with a 49% LDL-C reduction. Which of the following agents is most likely to provide additional meaningful LDL-C lowering? Evinacumab, icosapent ethyl, bempedoic acid, or fenofibrate? And we'll have our audience answer. And Sam, I'll let you speak to those
Yeah.
results.
So evinacumab is winning, and that certainly is true. Icosapent ethyl will actually increase your LDL a little bit. We don't really know for bempedoic acid yet. Fenofibrate may help, um, but I would certainly go with evinacumab first.
Great. And so, Sam, I'd like to turn it back over to you now for case
Okay.
number 3.
Okay, so this is Cody.
Oh,
Oh, we have Allison is going to speak first.
So when I was 35, my family had moved again, and I had a new cardiologist, and he wanted to do a sort of a baseline treadmill stress echo with me. So he had it for his own records. He was there with me. And we started the treadmill test, and about 12 minutes in, I was feeling fine until I wasn't. And I had a heart attack and sudden cardiac arrest on the treadmill. If I had not been in the doctor's office, I probably would not have survived. And I remember waking up to the chaos around me and just being very scared and thinking, this can't happen. My kids need their mom. 3 days later, I had a second open heart surgery and had a bypass of the right coronary artery and a mitral valve replacement. So after this, I went to my doctor, my cardiologist, and I said, there has to be something else we can do. I cannot keep doing this every couple of years. I'm scared and I want things to change. So he started looking for things I could do. He found a clinical trial that I could participate in. It was for PCSK9 inhibitors. And as part of that trial enrollment, I had genetic testing done. To my surprise, I was 35 years old, had had a heart attack and 2 open heart surgeries. That genetic testing showed that I actually had homozygous FH. And while it seemed to fit with everything that I had lived through, my family and I were still shocked. Like, how had it taken so long to get to this diagnosis? But with the new medications and the knowledge of this diagnosis, then I added the ANGPTL3 inhibitors on top of everything else I was doing. And today I'm happy to say that I am in range. And I think that is truly amazing. I do have hope for the future. I have found a community of people through Family Heart Foundation who live with FH. I'd never known anybody prior to my heart attack who also had FH. And today, through Family Heart, I know 30 people who have HoFH and hundreds more who have FH. So I believe that the future is bright. And today, with the new medications that are less cumbersome and less time consuming, I am hopeful that more people will get an earlier diagnosis and will get earlier treatment, and that we might be able to reverse some of the disease that I live with today. But this question still remains of how this diagnosis was missed. I mean, I had caring teams of doctors, I had everybody doing the right things, and I was treated for FH. It just seemed to be missing that piece of my mother's family history, which in hindsight was probably demonstrated in my paternal grandfather's early heart attack. But I know today with the diagnosis that I can press for more and better treatments for myself. I know I need to push for my son. And I have no doubt that for everyone who has homozygous FH, early diagnosis matters.
Thank you, Allison, for sharing your story with us. We'll now move on to our third case, which is in my wheelhouse as a pediatric cardiologist. This is Cody, who's a 4-year-old boy with a family history of FH. His mother has genetic high cholesterol. He also has a heart murmur at the sternal border radiating to the neck. And otherwise, he is healthy, active, and has a normal BMI. His mother has very high cholesterol, has been on treatment for several years, has a strong concern about genetic causes. Maternal grandfather has a very high cholesterol and had an MI at 42. And the father has not had any prior lipid testing, and one of his parents takes a statin. So Cody's cholesterol is through the roof. His total cholesterol is 654, LDL 586. His LP little a is normal. Secondary causes of elevated cholesterol have been excluded. And in a child, this is pretty easy because if you have nephrotic syndrome, you're edematous. If you have liver disease, it's known. And if you have thyroid disease, you don't grow normally. We've also gotten an echocardiogram, and he has mild aortic stenosis with a peak gradient of 25 millimeters of mercury. And I just want to make this point about HoFH. that aortic stenosis actually affects 25 to 30% of these children. And in my experience, a child who has a gradient at this age at some point in his life is going to face aortic valve replacement. So, Pam, I'll flip it back to you. Would you consider this definite HoFH based on LDL-C and family history?
Oh, in a child with a level this high, yeah, absolutely. This one is definite.
Thank you. So who else in the family might be affected? Well, we've gotten a lipid profile on the father, and his LDL turns out to be 202, and his sister has an LDLR variant, and her LDL is 180. So, what are the next steps here? What would you be thinking about, Pam?
Well, I think for Cody, it's treatment. And, technically, the father should be the family
Yeah,
needs.
I'm referring the father to you.
Okay, okay, I gotcha.
And the sister is below the treatment threshold and is only 2. So you would consider treating her for an LDL over 190 at about age 10.
Mhm.
So, how to do genetics refine the diagnosis? Well, it turns out that each parent carries a different LDR variant associated with FH. One is likely receptor null and one is receptor defective. Cody carries both variants consistent with HoFH, and his sister carries just one LDR variant consistent with heterozygous FH. I do want to make this point that we're casually saying these variants are receptor null or receptor defective, but the reality is in clinical practice, you have to really test this. So, you would give a patient at least one dose of a PCSK9 inhibitor to make sure that they're truly null or they may be defective. So, what initial management do you start now? Uh, Diet counseling, statin, specialist referral?
So this is, when we reviewed that chart, Sam, the only FDA approved therapy for a child at age 4 is actually evinacumab. The statins are at 7 and or 10. Um, Although I know customarily HoFH, we still use it. So I'd be interested as a pediatric cardiologist, how do you approach it?
Well, pediatric cardiologists are cowboys, and we're used to things like transposition and life-threatening newborn type stuff. So yeah, this is basically you pull out all the guns and start firing. So this is one thing we didn't discuss for your patient, but we image these people right away because this is someone who actually could have a heart attack before he turns 20. So usually soon after I see these patients, I'm getting a CTA or at least an aortic MRI. And in Cody, it actually showed a 3 millimeter lesion in the descending aorta. So he got sequentially started on a statin, ezetimibe, and ANGPTL3, and his LDL turned out to be 152. He responded to each medication in turn because he does have the one receptor defective um, uh, variant. So, how often do you monitor LDL and repeat imaging? And when do you consider further intensification or apheresis in someone like this?
Well, I'm going to turn this one back to you as the pediatrician here.
Sure.
You gave
Uh,
me his father, so I'm going to leave him to you.
Okay, good. So basically, once I get the LDL down into the heterozygous FH range, I then intensify based on the recommendations for heterozygous FH. So since he's 4, I would not intensify his therapy because he's under 190. And then I would image him every couple of years to make sure that his atherosclerosis hasn't progressed. Now, I would also be doing an echo every year to follow his aortic stenosis because that could progress, and aortic stenosis could end up being his first major event in this setting if you can control his LDL. So we're really managing 2 potential heart diseases in this particular patient. And then Pam has shown this variable response to alirocumab. I'm not going to dwell on this. Um, but evinacumab works great in kids, and it also lowers LP little a, and it works basically, in all kids, and that is why it's approved down to a year of age. This has really opened up a new horizon for HoFH therapy in children and brings up how early can we identify these children, because if we don't start treating until 5 or 10 years of age, that's 5 or 10 years of LDL exposure at levels well north of 500 milligrams per deciliter, which is a lot. So, next question. Which statement best characterizes the efficacy of evinacumab in available evidence for pediatric HoFH patients? Efficacy only in LDR defective patients, substantial LDL-C reduction regardless of LDLR mutation type, superiority to LDL apheresis, no benefit in patients on concurrent PCSK9 therapy. So go ahead and answer this one. And again, the majority of people have this right. Um, um, yeah, it works in everybody. Okay. So early screening of at-risk children is essential to care, and this is something we're confronting right now. The earlier you diagnose FH, the bigger the treatment bang you get. We want to screen all children early. If heterozygous FH has been diagnosed in a parent, or there's a family history of premature CVD, ideally recognized as early as possible in as early as 2 years. Now, for a potential homozygous child, you would screen at any age if the family history is positive on both sides. Next. Oh, I'm sorry. I'm the next. So optimizing HF care through early diagnosis, timely treatment intensification, and lifelong family-centered management is critical to preventing premature, potentially fatal ASCVD. Anything you want to add to that, Pam?
No, I think you made this point really clear.
So we know that HoFH is systemically underdiagnosed and undertreated. The Cascade FH registry here in the U.S. has many children and adults in it. Most of these people are not at goal, and at diagnosis, many were on woefully insufficient therapy. Some just on statins, very few prescribed advanced treatment, and some were even on no lipid lowering treatment. So we need more, and so all of this just kind of calls for action with regard to FH. I would want to highlight something which we're just beginning to understand is we should be screening for HoFH at very early ages. This is emphasized in the EAS HoFH statement, which was published in 2023. But there are several opportunities and we actually published this also in a life course paper, opportunities for screening. One is at pregnancy. Mothers can have their cholesterol tested. And if they're high, the father should be tested as well. If you have severely elevated cholesterol and a lipid profile, as we've illustrated with these cases, opportunistic screening. If somebody has their lipids for any reason, then you can move forward with an FH evaluation. In childhood, if children are tested at the age of 9 to 11, as currently recommended, if there are physical findings, which we saw in our case number 2, and now the new horizon is newborn screening, either potentially with genetics or assessing cholesterol on as part of the regular newborn screening panel. So this is a partnership. Allison's story has emphasized some of these points. So we want to make sure our patients and our referring physicians as well understand current disease treatment for HoFH. We want to make sure we understand our patients' goals, values, and preferences, because this is a lifelong endeavor. And unless we actually know our patient personally, we really can't come to the most effective treatment. We want to make sure we understand their prior therapies, both in the patient and in their families. We want them to understand all these new treatments, their benefits and risks, and we want to make final recommendations in partnership with the patients because an HoFH patient is with you hopefully for the next 50 or 60 years. Thank you um, very much. We have many people in our team who are important: our referring physicians, lipid specialists, genetic counseling, dietitians, our nursing support to improve medication compliance, and our office staff who make sure the patients come back and see us and we don't lose them for follow-up. So we're ready for the Q&A, and we can move on to that. Let's see.
Just do you see the first question? So the first question there, Sam, is how should lipid specialists coordinate with cardiologists, genetic counselors, and pediatricians for comprehensive HoFH management, including LDL apheresis when the goals aren't met? How do you work this at your institution?
Well, I think you have to start with the idea that to care for HoFH is a huge undertaking, and that your responsibility is to coordinate all these resources. So your referring physicians, these patients are going to be latched onto you pretty tightly, but you're going to need your referring physicians to give you alerts when things are running astray. You need genetic counselors um, to provide them guidance to help you get all these family members tested. You're going to have to reach out to people beyond your primary referring physician because these family members, could be living across the country. So a lot of these resources, it's important to kind of identify these resources ahead of time. And then I think what's not in this question is the most important partnership you have is with the family. Now, when I give lectures on FH, when I show my genetics slide, it's to show the doctor how many people this patient knows with FH. So they'll know people from all three generations. And you have to understand what that family's experience with FH is to be able to communicate effectively with them. And then the other question that I ask lipid specialists is what person is the most knowledgeable person in the world about FH? And the answer is a mother with homozygous FH.
Mm, perfect.
So that's
So
partner number one.
And here, there's a question about what are the protocols for patients with HoFH when they decide to proceed with conception, pregnancy, lactation. How do you handle evinacumab and lomidopide?
Well, I think evinacumab right now, I think, is not approved in pregnancy. I think I've heard some conversation about potential trials or at least, observational data in people with pregnancy. I think here in your patient, this was a little subtle thing we didn't do, is I would do a CTA and see how much atherosclerosis the patient has. And the more atherosclerosis they have, the more adventurous I would be, right? The patient's relatively clean. I think you can get the patient on apheresis if they'll accept it and go with your rosins. You can monitor that. If they have advanced atherosclerosis, then I think you have to think about and have a discussion about the potential safety. I think once you get past the first trimester and the risk of teratogenesis it's not a teratogen, then I think you can start pulling the gloves off.
Yeah, I find I'm very aggressive with imaging now, even in with severe heterozygotes.
Yeah.
I've been burned a couple of times on these folks. And particularly, they're oftentimes young, so calcium scoring is not sufficient. They haven't calcified, and they may have non-calcified plaque seen only on CTA. So I also am much more aggressive in imaging. We have
Yeah, I think we didn't actually put that in the case purposely to get to it in the kids, but yeah, once you see an HoFH patient, you want to image them and keep doing it.
And I think the last question here is, what data do we have on cardiovascular outcomes in homozygous FH with any of these therapies? But in particular, evinacumab, lamidopide, and maybe think about apheresis.
Yeah. Well, I think there actually is data on apheresis, which is, I think Gil Thompson has published some stuff. There are some papers on apheresis reducing outcomes. There's no real controlled trial evidence, but I think you just have to rely on the LDL-C exposure hypothesis. There are some interesting, striking examples. For example, Bert Wigman has published the case of a child who was responsive to PCSK9, and basically their atherosclerosis regressed on aortic MRI, so that the younger the patient, the more regression you get. Um, so I think, and I think these imaging studies need to be done. There's plenty of data that show imaging is directly correlates with events. And my own data in non-FH patients suggests that, you can use advanced atherosclerosis essentially as a surrogate for an MI as a primary outcome. There's no real difference. It's
Right.
just earlier in the course of the disease.
Well, that's him. I think we are out of time now. So if you want to wrap it up and take us home with these slides,
Sure.
actually, I'm
So
supposed
you can download slides from today's event. There'll be a multimedia version, and you can get more information at answersincme.com.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.